Dispofix, an external fixator for countries with limited resources. A training video for health professionals. Open fractures and fractures with severe injury to the soft tissue are very likely to be followed by permanent disability due to chronic infection or malunion. The victims of these disabilities are often younger people who would otherwise be able to contribute to the wealth of the nation for many years. Contemporary surgical techniques for the effective treatment of these injuries are technologically demanding and expensive. In many countries, the very limited resources available for health care are barely sufficient to treat life-threatening conditions such as malaria, diarrhea, or tuberculosis. In addition, in a society where most of the people live in a subsistence economy, where there are no social security or insurance systems or technical means to ease daily life, post-traumatic disability is a particular hardship for the patient and the family. However, fracture treatment is not a priority in developing countries, and so the first world's methods of yesteryear had been considered appropriate for fracture management there. But that is not true. The slogan, "Do not close an open fracture and do not open a closed fracture," should not be misunderstood to mean that plaster of Paris is the only way to treat fractures in countries with limited resources. Although most fresh closed fractures can indeed be well treated non-operatively, open fractures must be approached differently. In plaster, the immobilization of the bone fragments is achieved by the immobilization of the soft tissues. This does not achieve complete stability and necessarily subjects the soft tissue to more or less pressure. In cases of fractures with severe open or closed soft tissue damage, this might compromise the soft tissue even more and thus disturb the healing of both. Additionally, open fractures require sufficient stabilization in order to heal. Good accessibility for wound care is important too. External fixation provides both sufficient stability and accessibility. Moreover, the application of an external fixator is minimally invasive. It just needs a couple of small incisions to insert the shunt screws. No foreign material is introduced at the fracture site. Collaboration between doctors from developing countries and AO International has led to the development of an external fixator which meets the particular needs of developing countries. It's called the dispofix. In the following presentation, we will illustrate its components, demonstrate its use, and discuss its indications and complications. Components. Each set of dispofix is designed to be sufficient for the fixation of one fractured bone. The set comprises a 12mm aluminium rod, 4 gold-colored clamps, 4 5mm cell drill shunt screws, and 1 connecting bar if a second frame is required. An 11mm combination wrench is also necessary. The clamp components must be correctly assembled to accommodate the rod and shunt screw. Application. First, the fracture has to be reduced. The result must be checked either clinically or with an image intensifier if available. The reduction will be maintained manually by an assistant, but in this exercise, we will use a holding device. The shunt screws may be inserted using either of the hand drills or the universal chuck with T-handle. For this exercise, we will use this hand drill. Planning the insertion sites for the shunt screws should take into account the fact that the fixator will be more stable the closer the inner pins are to the fracture site, and the greater the distance between the inner and outer pairs of screws. In this example of incorrectly placed shunt screws, there is very little stability of the fracture. In our example of a mid-shaft tibial fracture, the appropriate insertion point would be medial to the tibial tuberosity. The screw should be angled in a lateral direction. The cell-drill shunt screw is designed to be self-drilling and self-tapping. Thus, drills and taps are not required, and insertion is a one-step procedure. This avoids all the difficulties arising from pre-drilling and tapping procedures, like losing the position of the hole or losing the reduction when changing instruments. Another advantage is an optimal bone-to-screw interface. The shunt screw must be inserted in both cortices, but the tip should not penetrate the far cortex. A change in resistance may be felt once the second cortex is reached. Note the optimum position of the shunt screw. The bar assembly is prepared with 4 clamps and mounted onto the first shunt screw. The clamp is then tightened using the combination wrench. The second screw is inserted as far distally in the other fragment as the length of the bar now allows. To insert this screw, the distal clamp is used as a guide. If a second bar is going to be applied, then the shunt screws must be inserted parallel to each other in the horizontal sagittal plane. Both clamps are now loosened to allow final manipulation of the fracture. The bone is released from the vise, and reduction is carried out. The clamps are then retightened. The bone is repositioned in the vise for completion of the exercise. The 2 remaining shunt screws are inserted through the clamps as proximal to the fracture as possible. However, a distance of at least 2 centimeters to the detectable edges of the fracture site should be maintained in order to avoid cracking the bone or entering the area of the fracture hematoma. Additional stability can be achieved by putting the bars as near as possible to the bone or the skin surface. Nevertheless, sufficient access to the wound and the possibility of further soft tissue swelling should be considered as well. The tightness of all clamps is checked in sequence. The fracture should now be reduced in all 3 dimensions and stable. In a clinical situation, the tightness of all clamps is checked during the whole treatment. Post-operative treatment. Post-operatively, an assessment X-ray is very helpful to check alignment and the correct position of the pins. If everything is all right, the patient should immediately start active joint motion and muscle strengthening exercises for the entire limb. This general rule might be limited by the condition of the soft tissues. However, one of the main advantages of external fixation is that it provides sufficient stability for both soft tissues and bones to heal. In lower extremity injuries, the patient proceeds to partial weight bearing with crutches progressively bearing more weight as the fracture consolidates. Indications. The main indications of the dispofix are fractures with soft tissue damage, regardless of whether they are open or closed. However, all other fractures that cannot be handled sufficiently by non-operative techniques can be treated with the dispofix as well. This could be non-unions or osteotomies for malunion. The dispofix is suitable for all fracture locations of lower extremity from metatarsal, via pilon, up to femoral fractures. On the upper extremity, fractures of the humerus and forearm, including the wrist, can be treated with the dispofix. The fixation of long bone shaft fractures with a simple unilateral frame, as demonstrated, can be performed well by clinical officers or medical assistants familiar with the technique. However, in the hands of an experienced surgeon, the dispofix is versatile enough to solve more complex problems, such as bridging pelvis fixation or stabilization after osteotomy. Now we will look at potential complications, how to avoid them, and if unavoidable, how to treat them. It is essential to avoid nerves, blood vessels, and tendons when inserting the shunt screws. For all bones, anatomically safe corridors have been identified where the insertion of a shunt screw is very unlikely to damage any functionally important anatomical structure. A further advantage in this context is that the opposite cortex does not need to be perforated by the shunt screw. So the sharp drill part at the tip of the screw cannot puncture or cut anatomical structures located beyond the bone. A second possible complication is varus or valgus malalignment. As demonstrated during the application exercise, sufficient reduction has to be achieved at the latest before the third pin is inserted. After that, no further reduction is possible. However, if there is a malalignment later, either the pins have to be relocated or the unilateral frame has to be converted to a modular frame. For that, the bar first has to be removed. After improving alignment, two of the pins always have to be connected by a bar. This allows for final reduction. A second bar is now connected to the two remaining shunt screws. To provide sufficient stability, these two bars have to be interlocked, using the connecting bars or shunt screws together with 4 additional clamps. This modular assembly is not recommended as a standard technique, since it requires 2 sets of dispofix for 1 fracture. Additionally, a modular frame might cause problems when dynamization in the load axis is attempted. Rotational malalignment. Apart from valgus and varus deviations, great attention has to be paid to rotation. Internal as well as external rotation will considerably disrupt the patient's gait. Unconscious attempts by the patient to compensate for this by counter-directional rotation in the hip might cause hip and/or back pain and may disturb knee function. During application of any external fixator to the lower extremity, the load axis has to be repeatedly checked clinically. This line runs from the anterior iliac spine through the middle of the kneecap and the ankle joint to the tip of the big toe. Pin track infection. In the long run, a problem of all external fixators has been the so-called pin track infection. This means that germs from the outside or from the skin migrate along the pin track down to the bone. Having arrived in cancellous bone, the infection can spread quickly to affect the entire bone, including the fracture site. Pain and redness around a pin site are early signs of pin track infection. Pus discharging from the pin site and or granulation tissue are signs of an advanced condition. If pin track infection has reached the bone, sequestration and pin loosening will follow. Pin track infection is more likely to occur under unhygienic conditions where daily sterile dressing of the pin insertion sites is not guaranteed. Moreover, the incidence of pin track infections increases the longer the fixator is in place. Usually, most fixators are applied as temporary measures, and after soft tissue consolidation, they are replaced by some form of internal fixation. However, advanced techniques of internal fixation may not be generally available or not appropriate for developing countries. Therefore, external fixators are usually left in situ until fracture consolidation. In complicated cases, this might take months. So pin track infection is of crucial importance in external fixation in developing countries. The new cell drill shunt screw used for the dispofix is designed to provide protection against pin track infection. This is achieved by a conical design whereby the part of the shunt screw resting in the near cortex is slightly larger than the screw tip, so the pin is slightly bigger than the hole, resulting in radial preload. Many experiments and histological investigations have shown that this is the best barrier to pin track infection known so far. Delayed union. If external fixation is the only option for fracture treatment, the phenomenon of stress protection may occur, thus retarding bone regeneration. Load is known as the most powerful inductor of bone growth. Putting the fracture under dynamic stress or load by allowing the main fragments to move towards each other in the load axis during walking is called dynamization. A simple unilateral dispofix can easily undergo dynamization. First, this requires the addition of a second bar. 2 clamps are loosened on one side of the fracture and on one bar only. Then the 2 clamps on the other bar and on the other side of the fracture must be released. This illustration shows how the dynamized double tube dispofix works. The clamps with the blue mark are loosened. With each step, the system can telescope slightly, but still provides enough stability in all other directions to prevent movement detrimental to fracture healing. Non-operative fracture treatment will remain the methods of choice for most of the fractures in healthcare systems with extremely limited resources. For those fractures which cannot be treated successfully by these means, but nevertheless cause significant disability, external fixation is a valuable option. The dispofix is an effective application of the contemporary technology of external bone fixation for countries with limited resources. Scientists and engineers have done their job well. Manufacturers and economists have to make the system available. Health administrators should realize its importance, and orthopedic surgeons must train district surgeons, medical and clinical officers adequately. Then it can become an innovation of appropriate technology and help make treatment successful.